All right. Good to see you all. Welcome, 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 welcome. It's our last time together of 2023. And it's great to see you all. Welcome today. Excuse me, we have a guest who's going to join us today. I'm excited. I'll introduce her in a little bit, but just wanted to start by just welcoming all of you. It's great to see you all. I don't know about you, but I am ready for this term to be over. My goodness. I am tired, and so I'm looking forward to a time of restorative rest. Starting last year, our university started closing for faculty and staff the week between Christmas and New Year's. So I am looking forward to being on vacation starting Friday. I hope everybody will get some time off as well for restorative rest and to take care of yourselves. So I wanted to just begin by inviting you all into the space, into community, by just asking if anybody would like to share anything with this community. Again, this is just how we start our time together. And this is part of what we do in HPRS. Every year when you're together, we always invite you to do this as part of building community and also celebrating each other. Too many times, I think we shy away from celebrating our accomplishments, and we want to lift each other up. So let me go ahead and make space and pause and see if anybody wants to share something by coming off a mute or putting something in the chat.
Yeah, I'll share. I just became president of our graduate student union. So just cool.
Awesome. Congratulations.
Yeah, thanks.
There's lots of applause and confetti and stuff going on. So people are cheering you on. Congratulations, Nicholas. That's awesome. Olivia, I'm celebrating. I survived the semester. Yes, I think we can we all say we survived the semester. I think we all need to celebrate each other for that. Yeah, congratulations. Oh, I love that. A good friend of mine is in C6. That's great. That's awesome, Jesse.
Yeah, it's really
Who's the
exciting.
friend?
Who is that? Yeah.
It's Santino.
Oh, yeah.
Yeah, we've known each other for years and years and years, and I don't know how it never came up, but it's very exciting.
That is awesome.
Yeah.
It's because y'all are too humble. That's why.
That's right. Yes, Corey. That's exactly right. That's exactly right. Oh, man. Well, that'll be good. You and Santino will be here. We'll be back in Baltimore for Summer Institute. So that'll be good. Yes. I don't want to lift up Corey's point about being too humble. And it is never gloating to celebrate the positive things that are going on in our lives. Right. All right. I'm not seeing anything else in the chat. So feel free to add something if you want to lift something up. I'll keep an eye there. And what I want to do is share my slides. I have just a handful today. Let me go ahead and do that first. Okay. And I'm sorry that some things my Zoom continues to show these captions at the bottom, so I apologize for that. We do have our captioner on who is captioning, but for now we're gonna just see this at the bottom of my screen while I keep talking. So let's go ahead and just I want to just make a few announcements. The first is that book club is coming up. We sent an email out on December 13th for book club, and that's the entire community. And I want to thank everybody who voted and weighed in on book club. And as that email said, we have 2 book clubs per year, and we usually do one in the spring and one in the summer, and we'll do the one in March when we have our spring gathering, which is virtual, optional, but we strongly encourage you to attend. There's really lots of good community building sessions. We do a session with the Robert Wood Johnson Foundation, and we're going to try to also bring in our book club. And so The book that was selected for book club is All About Love, New Visions by Bell Hooks. And if you haven't read that book yet, it's a terrific book. Part of being in book club is we purchase the books. We never want that to be a barrier for anybody to participate. And I want to say, even if you don't finish the book before book club, we still want you to come to book club because it's still great to talk about even what you've read. And I know that that's a barrier too sometimes. You people don't want to go because they thought, oh, I didn't finish the book. Trust. A lot of people show up at book club who have not finished the book, but we're there to just have a conversation about what we've read. And then people get excited to finish reading the book after they hear other people talk about it too. So I want to invite you to consider coming. And again, look at that email from December 13th, because you actually have to sign up so that we can then get you the book, either an e-version or mail you a copy. And then the second book that was chosen based on votes was a book that I'm excited to read. I haven't read yet, called An Indigenous People's History of the United States by Roxanne Dunbar Ortiz. And that will be, we're actually going to do that during Summer Institute, which we're really excited about. And we'll have some, trying to figure out how we want to make that work. And we've had individuals on our planning committee. We'll talk with them about that, but excited to also have space to do an in-person book club, which we haven't done yet. Everything's been virtual. So we might also maybe do one also virtually about this book, but want to just lift up these two book opportunities for everybody. The second announcement is, again, this is our last time together for 2023, and then we'll reconvene in a month, January 23rd, at 4 p.m. Eastern time, and that's when we'll begin to really lean in to policy and spend some more time thinking about policy. Today, we're going to talk about public health, building a culture of health, and sort of the public health system, and what does that mean? And we have somebody who has been working in sort of public health practice and the public health system is leading for a long time, who will be with us today, my colleague, Michelle Spencer, who I'll introduce in a little bit. But what I want to share is that while you are away, I don't know what your breaks look like. I acknowledge that for some of you, it may be busy. It may also be stressful. I know the holidays are stressful for me at times in terms of loss and remembering family members who aren't around. And I hope that if that is you and you're in that place, that you're also making time to take care of yourself in whatever way you need to. And to that point, I want to remind you all, if you need help, please don't sit in crisis. You know, we often have scholars reach out to us at a time when something's been going on for a while, where we, I think, could have provided some assistance sooner. And people say, I don't want to reach out. I don't want to bother you. It's never a bother. It is never a bother. So I invite you to remember we're part of your community. We're here to support you. And I'm using we because I'm talking about the MPC, and I'll say for myself, I am here to support you. And so feel free to reach out at any time. If I can be of assistance in any way, you know, we are here for you. I'm here for you. So I just wanted to remind you of that. And I hope that you're able to make time for restorative rest over the break. I hope that you're able to make time to take care of yourself. And just want to remind you of that. And so let me stop sharing for 1 second because our captioner is asking me something. So hold on 1 second. Everybody give me 1 second. So sorry, auto caption is not on. It says I've assigned you to captioner. Okay, so for anybody who needs captions, we're having some issues, and so just bear with us. We'll try to correct this. And so our captioner is trying to get things working on their side. So if you need the captioning, it's on the screen. The auto captions, I think, are just going. I don't know why they're not turning off, but please bear with us. We will fix this, I hope, shortly. Okay, and there'll be a link put in the chat for anybody who needs to see the chat. So I think that'll be the sort of short-term fix for a viewer link. So please take a look at that if you need it. Okay. All right. Let me pause and see if there's any questions about any of the announcements that I shared before we move on. Okay, not seeing any hands or anything in the chat. Thank you for dropping in the link for the captions. And let's go ahead and move on. As I mentioned today, we're going to have a guest joining us shortly, and we're going to talk a bit about public health and the public health system. And I will mention in a moment why this is an important part of this lecture. But I want to begin by acknowledging that not everybody in this community is from public health or familiar with public health. And that's intentional. It's intentional because we all have a role to play in advancing public health and health equity, and acknowledging that this program is intentionally designed so that any cohort has no more than 25 or 30% of the cohort who are from health or health-related disciplines. And because of that, it's important that we all sort of level set a little bit. And so today's session may be, some of it may be repetitive or familiar for some of you. And if that's the case, I invite you to chime in, provide some thoughts, some feedback on what you're going to hear today. And for those of you who this content is unfamiliar, I invite you to ask questions either during the session or follow up after. We understand, public health as a discipline. I've been in it since I was in college. And for some people, again, this is unfamiliar. And so that is fine. That's why we're here. We're here to sort of think and to be exposed to different approaches and disciplines. And this program is interdisciplinary. So I wanted to just lay that out and provide just a little bit of background. And so before I sort of share a few things, I wanted to begin by just asking for anybody, what is public health? What is public health? If anybody, feel free to raise your hand, put it in the chat. Like, what is public health when you hear about that? How would you define that? You're going to be around your family. If somebody said to you, what is that public health thing I keep reading about? I heard about COVID. What's public health? How would you answer that? And I'm keeping an eye on the chat for anybody, or if anybody wants to raise their hand or come off mute and offer some thoughts.
Hi, I don't know if you can hear me all right,
Yep.
'cause I'm kind of on the, okay.
We hear you.
Sorry, I really just needed to take a walk, so sorry I'm not on video, but I think one part of public health for me is this recognition that health is not just about the individual, and that there is a very communal aspect of health. And so I think sometimes about just, it's not just about eating carrots and exercising. It's also this idea that there are many systems that are interconnected and play a role in how individuals and families and communities basically impacting their health. And so, yeah, just hopefully that made sense, but that's one thing that I think about when I think of the word public health.
Yes, thank you so much, Ayan. And I'm glad you're taking a walk. All good. And I want to lift up a lot of things you said about sort of the community part, thinking about not just eating carrots or doing sort of behavioral things. You've also mentioned systems. And I want to lift up in the chat, Nicholas talked about the disciplinary study of the public's well-being and flourishing, especially as it relates to social determinants. Olivia lifted up promoting wellness and preventing illness for broad populations, and Tremaine, a discipline of advancing the health and naming physical, emotional, mental, spiritual health of the greater population, and how we as a community population interact with our environment at multiple levels. Yes. Anything else anybody want to lift up that comes to mind for them when they think about public health?
I think it was mentioned briefly, mental and spiritual health, but I also think a lot about just in my own city, in my own community, thinking about addiction services as public health as well.
Mm-hmm.
I think that that's something that sometimes gets overlooked or isn't viewed by the general public. I know,
Mhm.
especially like seeing in my own city, the way people talk about individuals that have addiction struggles,
Mm.
and seeing it more as a problem for them as opposed to a public health problem, which it is a not problem, but a public health aspect, something about public health that needs to be
Mhm.
addressed. And we've been talking about community care and being part of, wellness for broad populations. I think that that's really important, and just destigmatizing it, because like I said, the way I hear people speak about it in my own city is very disheartening. And yeah.
Yeah, thanks for lifting that up. And one of the things I heard you say too was emphasizing the importance of not just focusing on individual. And I heard you also sort of allude to sort of blaming the person. We think about, I think addiction is a great example. I've done work in obesity and the same kinds of things, right? Where we blame people for their weight without looking at the context and what one of the definitions that somebody lifted up related to mention the determinants of health, right? So thinking about the determinants of health. And certainly echo Alex, thanks for lifting up Jesse's comments about substance abuse disorders, mental health, and again, thinking about addiction and overdose and substance use as a public health problem. And I'll talk about that in a second, but I want us to be thinking about what does it mean to have something as a public health problem? Because when we think about the solutions, right? Like, so people say, well, why do we even need to define something as a public health problem? When we do that, that means we're saying this isn't a medical problem we're going to fix in just by one-on-one interaction with the doctor. It's thinking about prevention. It's thinking about the broader population. And so again, we'll talk about that a little bit more in a moment, but I want to just lift that up, and I appreciate these the echoing of these comments here. Let me go back to the slide and just share a couple more things that I want to just lift up that was shared. So let me go back over here. Forgive me, my computer is just moving really slowly today. All right, let's try this one more time. Okay. So I think can you see the slide now? No? No? Okay. All right, let's try that one more time. Thank you. All right. Okay. All right. I'm looking at you, Alex. Yeah, perfect. Thank you. All right. So just want to share just in terms of definitions of public health, just a couple of definitions. So this is CEA Winslow back in the 1920s defined public health. And actually, when I went to grad school at Yale, there was the auditorium we taught epidemiology and was nicknamed like after these individuals. Like these are like public health pioneers. But back in the 1920s, he said, this is what public health is. And he talked about the science and the art of preventing disease, prolonging life, promoting health through organized efforts, society, organizations, again, taking it out of sort of the medical model of healthcare of one-on-one interactions. We look at there's so many definitions of public health, but they all tend to talk about promoting and protecting the health of people and communities. There's this social justice framing to public health. We think about health equity a lot, and we'll talk more about that in a moment. I just want to also emphasize, when we think of public health, it's not the same as healthcare. Healthcare is certainly important. Hospitals, interactions with health services, with treatment, that's all important. But what we're not talking about here is sending somebody to the doctor to be cured. What we're talking about is prevention. We're talking about systems. We're talking about policies. And why this is important is that in HPRS, as we think about policies to address some of the problems we care about, this public health framing and thinking about public health and that lens for problems is just so critical. Right. And so just to share a couple of more things as we think about the mission of public health, I just want to share two framings on the missions. And this is one from the Institute of Medicine that talks about public health is really about fulfilling society's interests and assuring conditions in which people can be healthy. And the Institute of Medicine talks about this as all people, all conditions. And so we think about the social, economic, physical, environmental determinants of health. And the same thing, the World Health Organization globally is talking about how do we maximize the benefits? How do we keep people healthy, the largest number of people healthy, and thinking about the various determinants of health here too at a global level. And we're also looking at different resource allocations by countries. You know, there's a whole field of comparative public health where people are looking at high and middle income countries around the world, different systems, health outcomes to see how can we actually have public health strategies that are going to have the greatest gain. And my final slide before I introduce our speaker, I just wanted to just lift up earlier in talking about public health, there was mention of the determinants of health. And I want to just show this image. This is one of many images that are out there about how we think about the root causes and social determinants of health. And I love the tree analogy. I think for me, visually, it really works. And what this model is showing is if we think about a tree and the leaves of what we can see on a tree, and I'm noting that we can't see all illnesses, right? Like we can't always see depression or cancer, but if we think about a tree and the leaves, we think about the leaves as sort of the health outcomes. This model lists up the branches as the health behaviors that then lead into those health outcomes. So for example, you might look at smoking, which we know has a causal relationship with cancer. But it's not that simple, right? It's not just about stop smoking, but it's about looking at those social determinants of health that then facilitate those behaviors that lead to those outcomes. And so the tree trunk in this image are those social determinants of health, like the built environment, like education, like housing, like transportation. And then what this image then goes and shows you is that the root causes of health, so really below these social determinants, are those systemic related contributors to poor health, such as racism, poverty, heterosexism, classism, et cetera. And again, there are many, many images of this. This is one that I like a lot. It's one that I have evolved to using versus the one that hasn't shown the roots. But I think that this is so critical. So in this class, as we talk about the public health system, and I turn it over to Michelle Spencer in a moment, I want you to remember that we're thinking about these root causes. And later in the spring, when we start to talk about policy and we talk about policy solutions, you will hear me say many times, what is the problem beneath the problem? We oftentimes see something and we think, oh, let's just fix that. But ask yourselves, like, what is the cause of this problem? Are we trying to really address smoking, or maybe it's actually the stress that's causing the smoking? Maybe it's the poverty that's causing the stress, that's causing the smoking. And so what we want to do is really figure out how do we get to those root causes, because that's where we're going to make an impact when we think about public health. So let me stop sharing my screen there. Just wanted to provide a foundation to cue up our speaker. And I'm thrilled to see my dear friend and colleague, Michelle Spencer, who's here with us today. And you can pin Michelle if you want to see her right big on your screen. But I'll just say briefly, Michelle is a practice professor here in the Department of Health Policy and Management at the Bloomberg School. And she is also the deputy director, it's the official new title, right, of the Bloomberg American Health Initiative. And Michelle is a public health practitioner who focuses so much on health equity, racial disparities, working with community. And by with community, I mean sharing power with community, lifting up community voices. She has served in so many different leadership positions, including being director of the Prevention and Health Promotion Administration at the Maryland Department of Health. She also spent time as chief of staff at the Baltimore City Health Department. She's been involved in legislation to help advance health equity in communities. And today she's going to provide some insights about public health and the system. And Michelle, I was just queuing up the room who include a number of people who are in health, but also many people who are outside of health who are coming into the space looking to lean into social determinants of health and how their discipline and system can help to achieve health equity and improve health. So thank you for being with us today. I'm going to turn it to you. If you need us to create any breakout groups for you to make space for people to go in to have conversation, just let us know and we'll do that. But the floor is yours.
Awesome. Thanks, Keisha. Thanks for the opportunity to be in community with all of you, and all of you scholars that are online this afternoon. I am always thrilled and sometimes a little nervous when Keisha asks me to do anything. She's so dynamic and so amazing that being in spaces with her, I'm sure you all sometimes feel a little bit afraid, but I learned so much from Keisha, and I'm so honored for the opportunity to share a little bit with you all today about the public health system. And so I would love to share my screen, and I am going to spend some time or leave ample time for us to be in conversation and discussion together, so that I'm not spending time talking at you, but that we are talking together. And so as I share my screen and go through this presentation, feel free at any moment, at any time, to interrupt me with questions. I'm not necessarily so great at being able to monitor the chat and all that's going on in the space. So feel free to just come off mute and say, hey, Michelle, I got a question about what you've just shared. And we can spend time dialoguing that way as well. And so with that, I am going to, after many years of sharing screens, try to do this. Let's see here. And 2023. And please do tell me what you see. Are you seeing the slides as yet or no? Probably not.
It's
but
coming up.
It's coming up. Okay, here we go.
And we can keep an eye on the chat too, Michelle.
Perfect.
And so your slides are up, but they're not in present. Yep. So you go into presentation mode.
And then I have to switch the screens, do I?
Yep. So we can see your note screen.
How do I do that? Do you recall? The
Right
setting?
there. Yeah. That display. Mm-hmm.
Perfect. Okay. So you are all seeing that title slide?
Yep.
Okay, awesome, awesome, awesome. Okay, so this is what we're talking about this afternoon, advancing health and health equity through the U.S. public health system. And again, I really would love for you to interrupt me if you have any questions. All right. Oh man, I'm sorry. Did I stop sharing?
You're still sharing, but you went to your
Okay.
your slides, but it's not, you gotta go back to the other view.
Okay, sorry, y'all.
All good.
Let me see, what am I not doing here? Okay, here we go again. From the beginning. I'm so eager to talk with you that I'm doing everything but that. Okay. All right, so the US public health system, right? I think just because of the spaces that we are all in, you all know this, it's a complex network of government agencies, clinical care delivery systems. It includes faith and community-based organizations, private businesses, and other organizations really working together to support the health and the well-being of all who are part of that system, all of us. And so I just wanted to note here that the history of public health has been really a history of humanity's battle with disease and premature death. And one of the things that I wanted to highlight is, let me go back. In the early 1800s, the public health system was primarily focused on sanitary living conditions. And we know that public health is critical, and yet it's often invisible. We also know that although there's a disproportionate amount of emphasis that's placed on medical care and treatment as it relates to injury, public health really takes this wide approach, and the approach of what are the factors that are contributing to good health. We know that cholera was one of the issues really where individuals saw that here was an opportunity for public health to work really closely in relationship with medical community. And we also know that there was the 1848 Public Health Act. And so where are we several decades later in the 1912s, where there was the opportunity where public health was involved in thinking about TB and malaria, again, with this emphasis on how does public health become involved in the system that allows us to think about these issues alongside clinical and clinicians, and what does that look like, and how can public health be involved in that? Certainly, it's a system that didn't necessarily have the same shared opportunities, because we know that the medical community really perhaps thought that there would be competition between public health and medicine if there was the shared opportunities for integration of the way we think about the systems together. And so we know that public health is interdisciplinary. That is not new to us. We know that the attention is to health behaviors, to social and economic factors, to physical environment, and to other issues. But we also know that 80% of health outcomes are based on, are not necessarily clinically based, but more within communities and within other factors that are associated to those outcomes versus the 20% that's more clinical. And we see here the components of the public health system that include federal agencies, nonprofits, and it includes private industries, as well as others. I want to just take a moment here, and you may have seen this depiction of the public health system that, again, requires social and government and community and faith-based organizations alike, as well as academic institutions and clinical organizations. The history, again, of public health searches for what are the effective means for us to secure health and prevent disease across the population. And we can't do this on our own. Public health can't do it on its own, and clinical environments can't do it on their own. We know that health involves all of these dynamic, and it includes the clinical aspects of physicians and mental health providers, and it includes areas such as parks and recreations and neighborhood organizations and nursing homes. And you know that public health focuses, right? The system focuses on the 3 Ps, right? We have the prevention, we have promotion, and we have protection. And this is the way we think about the way we do the work. And certainly the way we do this work, we also within those 3 Ps think about what the 10 essentials of public health are. And so I'll go through this super quickly, noting that these 10 essentials are all part of the 3 Ps of protecting, promoting, protect, and I've just lost the last P, but thinking about this in terms of assessment, policy development, assurances with a focus on equity. And so you see here, public health thinking about how we assess and monitor the health of populations. How are we investigating, diagnosing, and addressing the health problems that are facing communities? How do we communicate effectively to inform and to educate individuals about what's happening in communities, as well as along what are the factors that are influencing their health? I heard Keisha in her presentation talk about tobacco and what the impacts of tobacco and why, and what are some of the social factors that are impacting why individuals are using tobacco products as an example. So how do we communicate about the impacts of the things that we do? How do we strengthen, support, and mobilize communities and partnerships to improve health? And then how do we create, champion, and implement policies, plans, and laws that impact health? And this is, again, within the essentials of public health. What are these? These are the first 5 of the ways we think about the 10 essentials of public health, but certainly thinking again about this as it relates to assessment, policy development, and assurances. And then as we move through this, how do we utilize the legal and regulatory actions that are designed to protect the public's health? How do we assure an effective system that enables equitable access? Again, how do we build and support a diverse and skilled public health workforce? How do we improve and innovate public health functions through ongoing evaluations? And how do we build and maintain a strong organizational infrastructure for public health? One of the things I do want to mention is that Maryland is right now, there was legislation that was passed earlier this year that created the Maryland Commission on Public Health, and really to do exactly what these 10 essentials are, to develop a strategic plan for the state of Maryland that really looks at the public health infrastructure and what are the opportunities to improve that structure? What are the opportunities to reshape and reimagine our public health system in the state of Maryland currently? And this legislation, again, just passed in April of this year, And the implementation of this was to begin in October of 2023 and go through 2025 for us to really think about what is happening in our state and what are the opportunities to really move public health infrastructure and public health forward, thinking about the system of public health and the interdisciplinary relationship between clinical, like the clinical and the non-clinicals, as I've just outlined. So here are some headline and journal articles. Just last week, we saw Kaiser Family Foundation noted that Millions had an article on opioid funds and what is happening with opioid funds across the country. We saw earlier, also last week, there was some articles on traffic deaths, and we know that public health is not just one specific issue area, but it includes the entire system. This paper that I have here, The Impact of Chronic Underfunding on America's Public Health System, is something that I would recommend you all reading. It really takes a look at where we are, and this is 2021. And so certainly some of these things remain steady and others have changed. A lot of things that we have noted given the pandemic, we saw the decrease in life expectancy, and we saw the disparities in terms of race, in terms of demographics, in terms of geography as well. And what are some of those impacts across our country and what is happening within the system? I was reading an article earlier this week, and the chairwoman for the House Appropriation noted Rosa de la Roja, and I might be saying her name incorrectly, but she said, we are not adequately prepared to respond to public health emergencies at scale. The public health system in its current structure is not adequately able to respond or prepared to respond to public health emergency at scale. And that says a lot for a country who spends so much on our clinical care and also tons on our public health infrastructure as well. And so I just want to note that. I want to spend some time giving an example of a program that I was involved with at the state that really looked at how we think about the public health system interfacing with community and interfacing with government. And so this was the Maryland Health Enterprise Zone Initiative. And this was back in, and I'll go through this in a little bit, but in 2012, again, using legislation, thinking about what is happening in community, looking at disparities, and how can we begin to address that. And so the determinants, this was really what the dean of the School of Public Health at the University of Maryland at the time, Dean Reese, was very clear that we have an issue here in Maryland, and how are we going to address all of these different factors that are contributing to health and disparities in our state. And he started by noting that the determinants of health are beyond the capacity of any one practitioner or discipline to manage. And he noted that we must collaborate, and he lifted this certainly from the Institute of Medicine back in 1999, but he shared that we must collaborate in order to survive as a discipline, but also as professionals attempting to help our communities and to help each other. And we know that the World Health Organization notes that the social determinants of health are non-medical factors that influence health outcomes. And I think when we begin to think about that, and when we begin to realize that we understand that there are all of those other factors that include income and social protections and education and food insecurity, all of those things, including housing and our built environment, really contributes to the factors in health outcomes. So one of the things that we looked at here was this linkage between community health and primary care. And again, thinking about the importance of integrating community health and primary care through this managed care community health worker model, and thinking about, again, the impacts on those social service and social supports. So I'll just lift this really quickly. CRISP, I don't know how many of you are familiar with CRISP, the Chesapeake Regional Information System for our patients. And so all of us are part of that system. If you get your healthcare here in the state of Maryland, you can opt out to not have your clinical information shared. But all hospitals all acute hospitals are part of CRISP. There are over 1,300 provider organizations, and more than just about 18 million individuals who are part of this system as well. And so CRISP, as it notes here, serves Maryland, West Virginia, and the District of Columbia, and really thinking about if we are able to have information shared across providers, then how do we think about coordinating care, both at the clinician level, but also care in community. And so here, and forgive me if these are things that you all know and are familiar with, but these are the methods for identifying high need, high cost individuals. And you see here that much of that identification happens at the time of readmissions, at the level of admissions and readmissions, and seeing that there's a frequency of repeated emergency department utilization. And so I think there's for many of us and the folks who worked on this at the National Association of Accountable Care Organizations, we're really saying that people living with clinically complex needs and have functional limitations also incur high healthcare cost. And so what are the things that we should be doing to help address some of that? You see that the social determinants of health needs are about 43%, but we know that there is so much more happening within that particular with individuals who are in that 43%, recognizing that there's so much need happening in community that oftentimes individuals are visiting and repeatedly visiting the emergency room departments to get some of the social service needs met. And we can talk about that as well. So for the Health Enterprise Zone Initiative, we saw the Office of Minority Health and Health Disparities at the time that this legislation was being considered, recognized that there was excess charges for Black-white hospitalization disparities that were over $814 million in 2011. And again, this was at the time that the legislation was being drafted. And we see here that these represent hospital charges, but do not necessarily include physician fees for hospital care or for emergency room departments or for outpatient costs as well. So that's when you think about that $814 million as a real disparity in terms of Black-white hospitalizations. So what we found, again, this is at the time of looking at drafting the legislation for the Health Enterprise Zone, that in Baltimore, if you live in Roland Park versus Madison East End, which is about a 5-mile radius, you see here that the income difference is about a little less than $60,000. You see unemployment is 3.4% in Roland Park versus 14.4% in Madison East. And I think critically important as well is the years of life expectancy. And so if you are living in Roland Park, you are expected to live about 83 years. And if you are in Madison East End, again, 5 miles away, life expectancy there is about 45 years. And so we see that this 18-year gap in life expectancy within 5 miles is something that the legislation considered. And also not just the cost, but the cost of life loss, the cost of productivity, the cost as it relates to economics, and certainly the quality of life within these areas. And let me not forget to note the homicide rates within Roland Park versus that within Madison East End, which is also consequential to life expectancy as well.
Michelle, this is Keisha. I just want to just take a moment and just lift up this point that you just made in this image and just say that probably for almost everybody on this line, you can think of communities where you live, where you see the strong tie to what Michelle is showing, right? So there's people talk in public health about how zip codes matter for health, right? And I think you can see that here. And these maps have been replicated, these types of maps all over the country, and you can see similar things in many other cities. And I think for me, Michelle, curious to hear too what you think. I know when I show these types of data, people always feel like this really emphasizes the importance of the social, structural determinants of health, right? Because you're seeing, well, what is it about 5 miles apart that's really creating these significant differences, right? 20-year difference in life expectancy. And when you start to look at the factors you list here, and there's so many others, right? That access to good education, access to transportation, all of the resources that you mentioned, I think it just helps to really unpack what's driving these differences. So I just wanted to look that up.
Yeah, absolutely. And I think I think showing the imagery just helps to highlight, I think for those, I say sometimes for those in the space that are runners, and so you would think if it takes you an hour, right? I don't know, if you're a 12 or 14-minute mile runner, so it may take you an hour to run from one area to the next, or even if you're faster, right? It may take you 10 minutes. So in 50 minutes, you can go from a very affluent area in Baltimore City to another area that has health outcomes that are significantly different. And when you think about the impacts to quality of life and to community, what does that look like and what does that mean? And so thank you for lifting that, Keisha. So again, these are the things that we considered. So we realized, again, that the areas with the worst health outcomes and the most health disparities also cost the state the most. And so with that, the legislation was drafted in 2012. It was Senate Bill 234. It was the Health Improvement and Disparities Reduction Act. And the criteria was selected because, so let me just note what is underlined here. The legislation established the Health Enterprise Zone to target resources to do 4 specific things: reduce health disparities, improve health outcomes, and reduce healthcare costs and hospital admissions and readmissions in specific areas of the state. We use data to measure this. There were criteria that were selected and that were reflected based on the disparities in the state. And these had to align, again, with these factors in terms of reducing health disparities, improving health outcomes, and reducing hospital costs and hospital admissions and readmissions. So what is an HEZ, right? HEZs are designated local communities, right, with documented poverty, health disparities, and poor health outcomes, where we believe that special incentives and funding streams are or could be available to address health outcomes by using healthcare level data, community level data, as well as individual level interventions. And in the state of Maryland, we had there were 19 applications and 5 zones were selected. And 5 of these each of these were in different areas across the state. You see here that Anne Arundel Medical Center, Bon Secours, and MedStar are all part of a hospital system. Prince George's County and Caroline Dorchester are part of the local health department systems. And again, thinking about the intersection of community, medical, clinical, as well as the community and public health systems and how they're interfaced and how they interface in addressing the health disparities in the state. And so for the HEZ, the criteria that we use were that communities or a continuous cluster of communities defined by the zip code boundaries was one of the criteria used to identify and to determine whether a zone could be, a community could be qualified as a HEZ. There had to be a population of a minimum of 5,000 individuals. The community had to demonstrate greater economic disadvantage than the Maryland average, and that demonstration was based on Medicaid enrollment rates as well as WIC participation rates. And it also needed to demonstrate poorer health outcomes, poorer than the Maryland average. So that included a lower life expectancy in specific areas, as well as the percentage of low birth weight infants. We know that the population had to be small enough that it allowed for incentives to be offered, but also large enough to have a significant impact on improving health outcomes at a community level, and also large enough to have measures that were stable and could be indicators of disparities. And so all of those things were part of the criteria for whether a community could be designated as a health enterprise zone. This is just a map that communities were able to go on the Maryland State Health Department's website. They were able to type in the name of the community or county that they were interested in working in. They typed in the zip code, and what populated was the average life expectancy, as you see on this middle portion here, as well as the average low birth weight, what Medicaid enrollment looked like, as well as WIC enrollment. And you see the darker shaded areas, you see here that the Medicaid rates were higher in those particular communities. So you have here in Prince George's County, in Montgomery County, and in Baltimore City and parts of Baltimore County. I think for us, as we were thinking about the legislation and at the time of implementation and reviewing these applications, that how do you develop health what does a health outcome metrics that would be stable enough for a small geographic area, but also have enough data available that you can really make impact and have outcomes. And so using, again, Medicaid data and thinking about low birth weight and then life expectancy were some of were what we found to be the best matrix for thinking through and coming up with what those qualifying factors could be. And so these 5 that were selected, again, they're in different areas across the state, Baltimore City, Anne Arundel County, Prince George's County, on the Eastern Shore, in St. Mary's, as well as in Dorchester County. The zones were unique, and each of them were tailored, and their programs were tailored based on what was happening in those specific communities. And, you know, I can absolutely talk more, share more if you have specific questions about what was happening in each of those communities. I'll just share a little bit here. That's an important context to know. At the time of implementation of the Health Enterprise Zone, the Affordable Care Act was ending its first open enrollment period. Maryland is a Medicaid expansion state, and so many of the individuals who were eligible for Medicaid were also eligible to have greater supports and greater coverage. And then Maryland, at the time, again, of implementation of the HEZs, we were going through global budgets, and our global budget process, where Maryland used the all-payer model. And part of the all-payer model is that individuals who were admitted to hospital, if they were readmitted less than 30 days, the hospital would not receive payment for that readmission. And so really moving from volume-based care and volume-based reimbursement to value-based. And so hospitals were not being reimbursed if they readmitted an individual less than 30 days after discharge. There was emphasis that was placed on care coordination and community clinical linkages. And so, as I showed you in a previous slide where we looked at the model of community linkages and care coordination with the community health worker centered, really thinking about what are the opportunities to ensure that when individuals go back into their communities, that their care, that the level and quality of care they are receiving is happening within their community. And then lastly, we were part of the global budgets incorporated this community integrated medical model. And so with that, this is really small, but this is a snapshot of what was happening in each of those 5 zones. The Annapolis Community Health Partnership was in Anne Arundel County. It served a population of 36,000, almost 37,000 individuals. They had a their budget was one of the smallest in transparency of 800,000. And they focused on diabetes, hypertension, obesity, and smoking. And the thing I love about the Annapolis Community Health Partnership is this was a hospital system who worked with the housing authority in Annapolis and looked at their EMS data and the number of calls they were getting from 911 dispatch to determine where those calls were coming from and what the needs were. And doing that data analysis, they recognized that a number of calls were coming from one specific public housing unit in Annapolis. And the hospital worked with that housing unit and said, we would like to try something a little bit different and a little bit unique. And we would like to open up a clinic in the lobby of this apartment building. And it took a while to figure out the constructs and work with the housing authority and with the state in terms of permits and those things. But they were able to establish a clinic in the lobby of this housing authority. And what they saw is that a lot of those individuals who were calling 911 and going to the emergency department were now being seen in the clinic in that particular or in the lobby of that particular housing building. And what they saw is that individuals were going because they weren't taking their medications because they didn't necessarily know how to read it, or they were hypertensive and didn't necessarily know how to manage that in community. And so providing this kind of clinical care in community, that hospital saw a drop in the number of EMS calls. They saw increased utilization of individuals in that clinic for the types of appointments that they would be going into the emergency room for. And they were able to employ a physician, a nurse, and support staff to support the individuals within that housing unit. Keisha, how am I doing on time? I'm so sorry.
No worries. It's 5:02 and we wrap at 5:30. So I think
okay.
yeah,
Okay,
you still have
great.
time and
Okay,
yeah.
great. Thank you. And so a few others here, and we can talk about, what was happening in Caroline, Dorchester, St. Mary's County. Again, and you see that local health departments, right? Like just thinking about the public health system and what that means. Like, yes, we local, state, and federal agencies are responsible for the health of individuals and communities, but what does it mean to go a step further and think about how we can coordinate care in communities with individuals and with individuals and with clinical partners to address some of the issues that we're seeing? How do we ensure that if transportation is an issue, that we are bringing those clinicians and services to individuals where they are and to meet the needs in community? I'm just going to move ahead here. This is just even more details about what happened in each of those zones. And I'm happy to talk in detail, but I want to get to the end a little bit further down because I want to share like even greater good news about this. So Dr. Daryl Gaskins, Dr. Roland Thorpe, and some of our students at the time, Raza and Rachel, worked on the analysis of the HEZs. And what they found here, I'm not going to bury the lead as they say, is that the net cost savings from reduced inpatient stays outweighed the initiative costs to the state. It noted that implementing such initiatives is a viable way to reduce inpatient admissions and reduce healthcare costs. What I did not tell you, and I'm just realizing I did not share this, that the HEZs were funded at $4 million every year for 4 years. And so that's $16 million over the 4-year period of time. And what Dr. Gaskins and his team saw is that, and maybe this will be somewhere on a future slide, is that this initiative saved millions of dollars to the healthcare system in Maryland. So much so that there's future programs that I'll talk about in a second. But I just wanted to share this, right? Because we can't talk about what we do without showing data, right? And so blue line is the HEZ that were awarded, and the red lines were the HEZs that were eligible but not awarded. So we funded 5 HEZs. There were a total of 19 applications that came in. And what you see here is that there are, within the HEZs, there are lower average medium household, well, I guess that's not reflected here, but the inpatient stays were both reduced for those that were awarded as well as those that were eligible, right? And this is the Healthcare Cost Commission data, again, prepared by the Center for Health Disparities Solutions that Dr. Gaskin runs. And so you see here that there was a decrease in inpatient stays, both for the HEZs that were awarded, as well as the HEZs that were eligible and not awarded. What's important to note here are those factors that I shared with you earlier in terms of what was going on in terms of the landscape at the time of implementation of the HEZ. So you had the fact that Maryland was a Medicaid expansion state, you had open enrollment had just ended, so there were many more individuals utilizing the healthcare system, and that we were part of the global health budgets. And so we see here, but of course, I think because of the intentional services and supports given to the HEZ, you see that that blue line had more of a decrease than that of the red line. HEZ, inpatient HEZ and PQI stays, we also see that there were reductions there for those that were awarded, as well as those that were eligible but not awarded. And we see that that the PQI, I should just note, is defined as preventable conditions, which can be treated in community, but are often, but are seen in hospitals because that prevention did not happen outside of the clinical setting. And so we see that those PQI stays continue to decrease. And if you think about what I shared with you around Anne Arundel County, the housing unit, we would expect to see that because individuals are being seen and treated in that clinic, in their community, and not visiting the emergency department. And so Dr. Gaskins and team certainly had the evaluation, and what they found was that there were 21 healthcare delivery sites that either opened or expanded. Certainly about 100 full-time individuals were either added or retained. There were clinical individuals that were hired in terms of licensed practitioner or certified healthcare practitioners. The HEZ offered tax credits to individuals who were willing to work in some of the HPSA designated areas, including St. Mary's County and those on the Eastern and Lower Shore. The process evaluation also noted that that care coordination programs did target high utilizers and that the link to HEZ data systems help to facilitate data sharing and co-management. And that's what I shared with you earlier about CRISP, the Chesapeake Regional Information System, and how that system really helped us to identify where individuals were who were being seen in communities, but may have gone to a clinical space. And when we recognized that in the data, care managers were able to get in contact with those individuals to ensure that they were coordinating their care and being responsive to what their clinical needs were. Some lessons learned, and then was that collecting and sharing data, right, is like critically important. Provider recruitment and retention, again, having individuals working in clinical areas where the incentives were not necessarily beneficial to them. Many individuals said, I've already paid off my student loan, so the incentives for loan repayment may not be as appealing. But the needs, particularly of clinicians in Southern Maryland, were so great that we were able to note, we noted that retention and recruitment was an issue, but then also came up with identified incentives that really worked for the individuals and willing to work in those communities. And then thinking about patient and community engagement, and then certainly clinical and community care needs. Here is the thing that I would also note, that the program, per Dr. Gaskins, that the program was associated with improved access to care and reduced inpatient admissions and their associated costs. They noted that the reductions could justify continued financial investment from the state, and that policymakers should consider promulgating the intervention to other eligible communities. And so the HEZs has proven very beneficial to the state of Maryland, so much so that the 2021 legislative, what's the word, Keisha, that session, the legislative session. Yes.
Sorry.
Yes, in
I'm
2020.
saying session, I was on mute, sorry.
Yes, so the 2021 session, we were able to pass the Health Equity Resource Communities. And just a quick note here, and like this makes me so excited because we went from 16 million over 4 years to a savings of 98 million to the healthcare system. And again, that's Dr. Gaskin's evaluation. And we were able to present that to during the 2021 legislative session to policymakers. And that session, we were able to introduce legislation that established the Health Equity Resources Act. And so thrilled about that. That act is funded at 59 million, or provided 59 million in new funding over the subsequent 5 years. And 14 million is for pathways, for health equity grants, and nine grants were awarded in 2022. And then another 45 million that the applications just closed for new grants. So, I would say that unlike the 2012 law, the HERC, this particular legislation, is permanent. It is not a pilot. It has dedicated funding for 5 years and more, and with the same goals, right? And let me just go here. I'll talk about the goals in 2 more seconds, and then I'll open for questions. But we saw here that when this was proposed, 66% of Marylanders were in favor of the health equity resource communities. 25% weren't sure, and 9 opposed. And I will share with you that the funding for this legislation, what we had proposed was that there would be a 1 cent tax to alcohol. And folks were very much opposed to that. And and felt like individuals on the Eastern Shore could easily go to our neighboring state, Delaware, where there is not that same tax. And so there was so much discussion about that. And one of the things that the head of the legislative body said, this is so important. And she had a reserve fund, and she went into her reserve fund and ensured that even if there was not approval for the 1 penny tax on alcohol to fund the health equity resource communities, that she would use rainy day funds to support this. And, you know, there was not a penny tax. There was some funding that came from that fund, some funds that came from that fund, but this passed, and it passed with a number of colleagues in the General Assembly saying this is important, and how is this impacting my community? The folks were able to, again, we funded these in 5 specific areas across the state. And so folks were looking within on the Eastern Shore, saying how our lack of access to transportation and to clinicians impacting health in my community. I want to just draw your attention to this average life expectancy by neighborhoods. And I showed you 2 communities in Baltimore City previously, Roland Park and Madison East End. And this is Clifford Barrere in Baltimore City, and Cross County also in Baltimore City. But then if we go a little further west of the city, in Suitland, Maryland, and Prince George's County, you see that life expectancy is about 70 years versus Greenbelt, also within Prince George's County, at 86 years of age, life expectancy. And so that's a 16-year gap. And these are 2 different communities within the state of Maryland. And again, within within mile radiuses of each other. And so it's not just that this is affecting communities in Baltimore City, but we see this disparity in other areas in our state as well. And so this is my final slide here, the health equity resource communities. The same kind of we were looking for the same kinds of outcomes. How do we reduce health disparities? How do we improve health outcomes? How do we improve access to primary care, promote primary and secondary prevention services, and reduce healthcare costs and hospital admissions and readmissions? Let me just share this one thing before I open for questions. It is really, really hard in 4 years to reduce health disparities when we know that the system that creates health disparities does not happen in a year or 2 years or even 3 or 4 years. And so what I think we have been so proud to have been able to do is use that 4 years and see the tremendous impact that we used in 4 years to be able to leverage that to get new legislation and new funding to support this new legislation in the Health Equity Resource Communities Act. And being a champion for the place-based initiatives that helps us to think about what are we doing in communities that are addressing and speaking specifically to the challenges that individuals have in community is something that I think we as scholars and individuals who are focused on equity and reducing health disparities are called to do and are excited to do and embrace the challenge of doing, particularly when we see that those challenges are in under-resourced and in under-resourced communities, and those communities that are disproportionately impacted by lack of the kinds of resources that we see in other areas of the state. And so with that, I will stop sharing. And I think the last slide is, just who I am and where you can find me. But with that, I will stop sharing and open for questions.
Great. Thank you so much, Michelle. Really appreciate this. I want to just lift up, Michelle is so modest. Excuse me. This is such a great example of how research community has actually influenced legislation. So for everybody who's interested in policy change, this is the opportunity to talk to somebody who's been involved in not only helping to move policy forward, but through her positions has helped to make policy, and institutional policy, health department level policies, has also influenced state legislation. And I just want to just lift up Michelle's work to advance health equity and then reduce health and eliminate health disparities in the state of Maryland. I have a question, but let me pause and let somebody else talk and see if anybody else has a question before I jump with mine. Yeah,
I have
Alex.
a I'm
Oh.
sorry.
All right, let me go Alex and then Jermaine. Thank you.
Thank you. Thank you so much for this presentation. It was so incredible to hear about all the work you've been doing, first of all. I just wanted to ask, so these health enterprise zones, is that just in Maryland or has it expanded further and acted as a model for other places? This was just the first time I had heard of this term and I wasn't sure where it exists.
Oh, yeah. So thanks so much, Alex, for the question. And so that's great. It is only in the state of Maryland. However, we have consulted with Delaware and Rhode Island and New York on how they can do similar, have similar zones. Dr. Gaskins really worked with Rhode Island in what could be a model there. There's one of those slides, and I'm sure I'll be able to share the presentation with you, talked about some of the awards that the HEZ won, recognized by ASTO, which is the Association for State Tribal, now I'm forgetting, but the Association for State and Tribal Health, officials, but
Drop it in the
I got
chat.
that all wrong, huh?
It's territorial
It's
health. Meeting.
territorial. Yeah.
Thank you. Thank you. Thank you.
Thank you, Corey. I'll drop it in the chat. I'll drop a link in the chat.
Thank you. And so, won awards for the work as an innovative model for how you do community clinical linkages.
Oh,
Yeah. So thank you for that.
Thank you. That was really helpful.
yeah. Tremaine, you're up in the queue next.
Yes, thank you. So thank you for the presentation. It was very informative. Particularly the part we talked about where one of the solutions was to place a clinic within the housing community. And so I know we have initiatives like Healthy People 2030 and so forth. And, a lot of the work, my concern is that will we be able to see actually the change that we make? And I just wanted to hear your perspective on, having a 4-year project and actually seeing the change. And do you believe that that type of work is really not necessarily the future, but what we should expect from work in health policy?
Yeah, thank you for that, Tremaine. I think it was humbling to see after 4 years what we were able to do. And one, to be able to have the data that supports what we did through the HEZ, and then to be able to have new legislation that supports us being able to do this. We currently have 9 new health equity resource communities. December 1st, the applications for a second round of health equity resource communities closed. And so I think the state's commitment to doing this, to be able to see, we have so many different testimonials from individuals who said, there's a gentleman, Mr. P, and Mr. P did not use compression socks, right? Like it seems so simple, but, and so would just call 911 for 2 reasons. One, he needed compression socks, but he would call 911 because that was his way of getting it. And 2, he lived alone and wanted to be in community. And so when that clinic opened in Anne Arundel County, what the clinicians did there, which was pretty incredible, recognized Mr. P's need for being in communities and being with others, and gave him a job as the host to welcome individuals as they came into that space and still be able to monitor his clinical needs. And so, Tremaine, I hear you with 2030 and the Healthy People goals. I think being able to use innovative models that includes community, that allows communities to lift up what they need. I mean, these HEZ proposals were not proposals that were designed by anyone at the state. They were designed by individuals within communities, and the lead organizations were the organizations that I noted. But there were a number of law enforcement was part of some of these, right? Like they wanted to figure out how they can be involved. EMS was part of this, the 911 system, faith-based organizations. So for each of these 5 communities, I might have just noted, not might have, I noted who the funding and who the funds went to, but there were a series of organizations that were all within community that supported that. And I think I firmly believe that we can't make impact unless we are including everyone who touches the system, and being able to give, you know, ample space and voice for those individuals. So I personally do believe that this is one way of influencing equity and ensuring health equity in within health, but certainly if we impacted in health, we impacted in other ways, including education and economics and all of those other housing and all of those other factors.
Great. Thank you so much.
Of course.
Great. I saw Marcus's hand go up, and then they'll take a question from the chat until your hand go up too, Austin. So Marcus.
Hi, Michelle. Thank you so much for the presentation. Something that was really interesting to me is when you were talking about the legislative session and how the members did not want to put a 1 penny tax on alcohol. And you know, when you said that, I'm like, oh, that seems reasonable. It's just a cent. But to get so much pushback against that, my question is, what would the process be, or how would the process be different if you advocated for that particular tax to go on the ballot in November or during a primary and have the people vote on it versus the legislative session just come to a decision?
Yeah, that's a great question. Marcus, I have no clue how that would go, right? I would hope, right? Like I would hope that we in community would do a good job because remember, on one of those very first slides, I also had media as part of the system and communication as part of the system. So I would hope that we in community would do a really good job of being able to say this is the impact. Like this is, you know, 1 penny on a 1 penny alcohol tax for individuals, recognizing that individuals are also part of that system and what that could do to lower healthcare costs overall, you know, would be a great talking point. But we would have to do that in a way that individuals understand what that means personally to them. I think I would hope to think that the humanity in each of us would rise to believe that 1 penny wouldn't be something that would be so detrimental, particularly to those who are in need of the supports that the system offers. I don't know how to end. I don't know, but I would be hopeful that we would rise to the occasion and vote yes on that 1 penny tax increase.
Thank you.
Yeah, thanks, Michelle. I just want to lift up too, Marcus, that you know, there's the power in ballot initiatives, right? And organizing to get the signatures to get something on the ballot. And I love that question. It'd be really interesting to kind of see what would happen if that went to the people. You know, Maryland's more of a progressive state. And, you know, even when we had a Republican governor, most people tend to vote more liberal. So, you know, it would be very interesting. Yeah, I appreciate that. Let me go to Imani's question. It was to add on to Alex's question. Michelle, could you elaborate on a few effective strategies you think may be important or salient to advance these zones in states where it may be more politically polarized? What it looked like to get buy-in in Maryland and get the funding. And if we don't get to your questions, we'll get answers and I'll send them out. So yeah, can you answer that one?
Yeah. That's a great question. I'm just thinking about that. I want to go back to what I mentioned about these weren't, the HEZs. Yes, like this was our thinking based on the data, right? Like we were able to say from the Office of Minority Health and Health Disparities, this is what we're seeing. In other states where that would not be compelling, I think what might be compelling is what is happening in your specific community. As I mentioned, none of these zones were written by members of the state or the legislature. Like literally we said, we have some funding available. Tell us what your needs are, and we will do our best to try and support. So I, could envision for communities and states that are not necessarily interested in a health enterprise zone. I will tell you, I will also share with you, Keisha, when you just said, we had the HEZs were under Governor Martin O'Malley and Anthony Brown. And and when Governor Larry Hogan came into office, it was, the zones are done, we're not doing this, we're not talking about it. And we had one more year, and there was still opportunities to spend down those dollars. And we asked for an additional no-cost extension so that we could, before it sunsetted, and the governor allowed that. But this, the health equity resource communities, I mean, it's the same. If you read it, it parallels, but we had to call it something different. And we were absolutely fine in calling it something different. And so this is under Governor Hogan. Governor Larry Hogan did the health equity resource community. So for us, it's the same type of legislation, the same kinds of outcomes. And so you market it based on what is happening in that particular state and what will allow you to address the health and social needs of that community. And if it means, calling it something different, then that's one avenue. May not necessarily be like the most politically sound, right? But you do what you're able to do to influence the community that you're trying to see the greatest outcomes.
Yeah, thank you for that, Michelle. And if I can circle back to our Academy Health panel, remember they talked about framing and messages and narrative. Like this is exactly what Michelle is talking about, a narrative that worked for a Republican, fiscally conservative governor to still move forward with something that addresses equity we don't often see in some more conservative states. So thank you so much. I'm noting that we are at time. I mean, there are more questions and Michelle, because I have Michelle's phone number, I'm gonna just say I will call her and get these answers to these questions we didn't answer, and I'll post them on the portal. If that's okay with people, I want to respect that it's late for folks, and also our speaker who is here today after a long day at work. So I appreciate you. And if you had questions, Austin, I saw your hand, send me an email. I'll get that too, and we can post these in the chat. So Michelle, thank you for being with us today. I hope you saw the applause and the hearts, and I think it was, thank you for just being such a great role model. And to everybody who's here, we'll get Michelle to come hopefully see you all in person when you're here in next summer for the SI. She's right here. So hopefully she'll come visit with us in person so we could spend some more time with you.
Thank you.
So
Keisha.
thank you.
Thank you all. Thank you.
So take care, everyone. Stay well, stay safe, safe travels if you're going anywhere, if you celebrate these holidays, enjoy. And if you don't, I hope you still make time for restorative rest and take care of yourselves. Thank you again, everyone. Take care, stay well. Bye-bye.
Take care.
Thank you. Happy holidays.
Happy holidays. All right. Oops, stop the recording.